This conference will now be recorded.
Okay, so hi everyone. We are starting our third webinar about modeling system dynamics, modeling on the COVID crisis. We think Karim is in here, is going to present his model about the age-specific policies on the virus. I would like to thank Karim for supporting with the platform and making this simulation. So without no more word, I would say let's go on, Karim.
Okay. Bem-vindos todos. Boa tarde, or boa noite for some of you. I'm glad to be here. I am going to be talking about the model that's disaggregated by age that we have. So just to give some background, we were doing a lot of SER modeling at the very beginning. That's susceptible, exposed, infected, recovered. And those models showed us a few things. So the first thing was that the standard model leads to a much lower average residence time than you specify, because the largest fraction material exits immediately because it uses a first order material delay. And there's also a strong correlation between the age and each of the symptoms, the levels and the severity, and people's behavior. So if you disaggregate by age instead of by severity, you might get interesting information. There are also policies around that. So you'll notice most models that are disaggregate by severity, and it's aggregate, right? They look at, X% have this severity and present at this time, et cetera. But we can catch new dynamics necessarily, and we can also test age-specific policies. For example, vertical isolation. If someone can mute themselves. Yeah, so we can also test age-specific policies. Just to look at the distributions for material delays, if we have a pulse here at the beginning, these are the different distributions based on the order of the material delay. And this first one is what is used in a standard SEIR model. You'll see this huge fraction leaves at the very beginning, and then you get this all the way up to ninth order, which is starting to approximate a normal distribution. So there are all these distributions that you could select that are skewed to the right instead of just defaulting to this first order behavior that you see in most of the models. I should mention that Tom Fitteman was building models similar to what I was building. He was seeing the same issues. So in a first order system, this is how it's typically modeled. You have people that get exposed and they become infected. The model's obviously a lot bigger than this. And we just have this draining process, which is a first order material delay. If we wanted to implement a third order, say we like this curve better, that's this one right here, the dotted one, then we would have to do all this. We'd have to go to several stages. This would be a third order, all of this. If I get my laser, it'll be clearer. All of this is a third order material delay. That's a lot of stuff to add for every single stock we want to do this to. We can simplify it by using the smooth built-in. This is in Sturman's book, and he recommends that if you want to do a stock flow chain, main chain, and you need to know what the values of the stocks are, you can just connect the inflow to the outflow and set the flow value to be a smooth. So we're burying the all that extra logic inside this built-in function, and this would be a third order. This would be a sixth order if we wanted to do that. But it doesn't work if you have multiple outflows. So for example, if I have testing that moves people out of here, or that people get moved out of here because we notice they have symptoms, then it doesn't work anymore. You can't just do this. I wrote a blog post about how to get around this by writing macros, and I provide the macros, and that is here. Now, we saw Bob's model last week. He was also working on this at the same time, and because this wasn't working, he used conveyors, which were closer, actually, surprisingly, much closer to the right behavior than a first order system. And the reason this is important with COVID-19 is this time lasts a very long time. It's been recorded up to 21 days where you're exposed and not showing any symptoms. In fact, then you could be infected and not show any symptoms, but this period can be very long, which is kind of unique. So it becomes extremely important. If this is very short, then it's not so important anymore, but it's very long, so it becomes really important. So that's what he did. And I should also say that this solution in here allows you to use whatever order material delay you want to make this work and have multiple outflows, well, 2 outflows only from a stock. But in version 2.0 of Stella, you can also use a conveyor and specify a distribution as well for the conveyor. So if you have the newer software and you don't need to rely on some other package, then you could use that as well. Let's just quickly review what an SEIR model would look like, especially if we add this 3rd order material delay or 6th order material delay. So we have these 4 stocks. Let's just start there. It's called SEIR because we have susceptible, people who haven't been infected yet, people who are exposed but not exhibiting symptoms, those who are exposed but exhibiting symptoms, and those who have recovered. Okay, SEIR. People become exposed. We'll talk about that flow later, but they become infected by this average time to show symptoms, and there is a whatever order material delay in here to give us their distribution. And then the same thing here on recovering. There's an average time it takes them to recover, and we have whatever order material delay we want in here. I was using 3rd order, by the way, but I actually made it a parameter of the model. And this should be pretty normal for everyone. We have our total infected contacts. We just add those together. We multiply that by the contact rate, and that gives us the total number of people that infected people contact each day. And we have the probability of that contact with a susceptible person. We multiply that and we find out how many contacts infected people who can spread the virus are having with people who aren't infected. And then we multiply that times our infection rate, and those are the people that become exposed. Very straightforward model. Normally this would just be a draining process. Not that part, sorry. This part and this part would just be draining processes, 1st order delays. This is, of course, our exponential growth is coming from here. So if I want to add testing, it becomes a little more complicated. I now have to quarantine those who are exposed, but only if I tested them exposed. Okay, so they have to be sent this way. The other stuff's still there. I'm not going to show it. And then they will eventually become infected. People who show symptoms, we're going to quarantine, and so they get moved up here. Notice we don't necessarily move everybody up there, and that'll become much clearer when I disaggregate it a little more. And then we have people recovering and from infected as well, right? So normal recovery from being infected. There are no deaths in this version, but that'll be added, don't worry. Okay, if I disaggregate by age, actually I can disaggregate by anything and it would look like this. I can disaggregate by severity, I can disaggregate by age, I can disaggregate by age and severity if I like. And then it looks like this. All of these things are now arrayed. Everything here is arrayed, and I added deaths. This is basically the model we're running underneath. And there are some interesting things in here that I want to show you. The first thing is the contact fraction. So this is by age, and it's a matrix sort of like this. So this is from China. This is their contacts by age. So age group here, contacts age group here. In the table I have in Stella, it's actually age group here, contacts age, it's the other way, it's flipped. But anyway, this is the data from China, and this also data, if you want to get even more disaggregated for policy reasons, they further disaggregate this by contact at home, contacts at work, contacts at school, and other locations. So you can get very serious about this. But I just use one set of contact fractions, and by the way, I just made up numbers that made sense to me based upon how people live together and generational differences, how they work together, and it actually turned out to look roughly like this. And then we also have this new thing, symptomatic fraction, because once we divide by age, not everyone becomes symptomatic. We can now disaggregate. A lot of younger people don't show symptoms, and we can disaggregate here that and only move the people who are showing symptoms up to here. And the other new thing, I already said we added deaths. Deaths are here. If we quickly look at the next page, which is a little boring, data, this is the data table I used, and from this age, contacting this age across the top. And fractions, these have to add up to 1 this way, but then we can do simple calculations to figure out who at what age contacted who, how many infected contacts per age group based on the ages of people who are infected. And the symptomatic fractions I used are over here based on the age groups. You'll notice I didn't do decades exactly. I split here because this group tends to mix with each other a lot more. And so I treated them, I kind of lumped them together instead of keeping them separate and putting the 16s through 18s with the 10 through 15s. Okay. So I didn't divide our known infected into mild, severe, and critical, but it's really easy to do that if that's the information you want. If you're trying to look at this and you're trying to find out the hospital capacities, it's extremely easy to get that information here because we just use aggregate fractions for those, and we can use the same aggregate fractions here. In fact, if we wanted to, we can get more specific and do those, have disaggregated fractions by age of what they are. Bob's model just used an aggregated fraction of, number of people that were severe or critical or mild, and that's what all the models are doing. So let's go look at the model very briefly here. You've probably seen this model, but I want to show some things about it. If you haven't seen it, it's on the isee exchange, and it talks about, the problems in Brazil about trying to do this vertical isolation thing that came up. And at the same time we published this, there was a huge set of protests in the US in the middle of April. And some people are still doing that, are still protesting, although there's other stuff going on now. So not so much that for the last more than a week. But people have still been protesting up until then, saying we should vertically isolate, even in the US. If we jump to this and we run this model, I added another thing, which I'll describe in a minute. If we run this model, we find out over time, I have deaths by age group here. I have the total deaths here, and then I have a distribution of the deaths to see it in a bar graph. It's a little easier to see in some cases. I also have the behavior over time of who was susceptible. Notice there are a lot of people still susceptible. If we stop closing down, this could get a lot more people could become sick. In any case, this is with horizontal isolation. This is what, in New Hampshire, we have a full lockdown, and that's what I know they had in Sao Paulo and Rio. In Manaus actually put that into effect also fairly early. If I switch to vertical isolation and I run it again, we find there are a lot more deaths. We also see the distribution changes fairly dramatically. There are more deaths in the older groups, but the younger groups are also hit harder than they were before. And this is pretty dramatic. And it's a lot more dramatic if you go and then change the size of, this is for a city of 1 million, but if I go back and change the size of the city to 7 million, it's a lot more dramatic. Now, one of the things that I changed here is I changed, before I tell you, I'll just show, if you haven't seen this, I just let you change how long the lockdown lasts and the effectiveness of the quarantine by each age and the size of the city, just very quickly. You can play with this on your own. I don't want to take all our time talking about the interface. But people here, and I think I read something about in Brazil as well, but I'm not going to don't hold me to that, but people here have been saying, why are the schools closed? The schools should all be open. The children have very few symptoms. The very few of them get very sick. For a while, the data for 10 and under was no deaths. Now it's some deaths, and now there are also some other complications that are coming up because of it. So there are reasons to leave the schools closed, perhaps for those reasons. You know, I don't know how you weigh that. But the real point of leaving the schools closed goes back to a 1992 study they did in Japan. And in this study, what they did, it was actually, they did a study of a government policy, right? So this was after the fact. The policy was, they'd already, you know, investigated this, and they'd already implemented the policy, and they already saw the results. So this is after this policy, what the results were. But they had the idea, they said, look, a lot of young people get the common flu, right? Whatever the common flu is, and it doesn't necessarily hurt them. It's school age kids, it doesn't hurt them. They get over it and they move on. The elderly, right? The seniors, the people 60 and over, or wherever you want to draw the line, a lot of them get it and don't survive. They can get more complications, they get pneumonia, they can die. So there's a fairly high death rate in the elderly population. And someone had the idea, well, they didn't close the schools because they didn't have to. What if we give the flu vaccine to the school-age children also? Because I don't know if you've ever worked in a school with school-age children, but disease just spreads through there like wildfire. If a flu comes out, everybody's got it within a few days. It just spreads like wildfire. And then they take it home, and then they take it to when they see their grandparents and whatever. They said, what if the school-age children are one of the primary vectors for getting the elderly sick? What if we inoculate the school-age children? Even though that won't really protect them because they're not going to really get that sick, will it protect the elderly? And they did a very long study on this, and they reported it in 1992, and it had a dramatic effect on the spread of flu in the elderly. It dropped significantly. So one of the things that I added to this just Tuesday was what happens, here's another age-specific policy. What if besides vertical isolation, which is isolating the elderly and in this case defined by 60 and up, and anyone who is at risk, they're not disaggregated in this model, so they're not specifically isolated in this model. My microphone's moving. Hang on one second. Okay. So what happens if I also close the schools? Well, this kind of surprised me. I expect the numbers to be lower, but not this much lower. But that's what happens when you run this model. The total number, hang on one second. My microphone's misbehaving. Okay, so the deaths among the elderly are about the same. These are what you wouldn't know, but about the same as they were here. There are more deaths in these categories here than there were before, but basically everyone from 16 to 59 is still at work or at university or whatever, and the death rate dropped dramatically compared to vertical isolation. So that's just another possible policy. I didn't calibrate this to anything. You'd want to go back and do more work around that. And that's the extent of what I wanted to talk about today. I will tell you, we're about to release another model that I built probably next week on the effects of the economy of the lockdown and whether or not the stimulus payments the U.S. government came up with had an effect. Well, I don't know if they had an effect, but whether they had the opportunity to have an effect, whether they could have had an effect. So that will be coming out. You can look forward to that. And I'm open to any questions.
Okay, thank you very much, Karim. I would like just to congratulate it was very clear, very didactic your explanations. I would like to start the questions making clear what's your vision about this opening that is happening somehow in Europe. People is talking in here in Brazil. What's your perception from your model, from your work? What is going to happen? What's your perception? What's your view?
Both of our models show that there's going to be a second wave. The question is when, and it's interesting. Our models show it's going to happen, mid to late summer, like maybe as early as August, instead of the fall, which a lot of people are trying to. I mean, everyone in the government here said it's going to be a second wave in September, probably, or October. It's interesting. Last week, I was in a presentation with the CDC. A guy who's been there his whole career and works in the pandemic unit. And he said that their models are showing the same thing, that they will we'll probably see a second wave in the US anyway. I don't know about everywhere else in the August timeframe.
Do you see any I would say dashboard or any measurement tools just to indicate when and how it could be a good policy for the opening?
So in the United States, there were specific guidelines that the CDC recommended for reopening, and that the Center for Infectious Diseases also recommended. And they all relied on sufficient testing and good contact tracing to allow you to safely reopen. And you still have to maintain masks, social distancing, frequent hand washing, all those things you still have to do. Those don't go away until there's a vaccine. You still have to do all of those things, but you have to be able to have enough tests, which we're starting to get to the point in the US finally where we do have enough tests, but we don't have contact tracing. And I don't know what's going on in Europe or anywhere else. In China, they have very good contact tracing and they have a lot of tests. So if there's a small outbreak, they can just close that area down, right? But they're a very autocratic government. They have a lot of control, and they also know like Big Brother. So that's how they can do contact tracing, right? They know where you were, when you were, and who was around you. So there are efforts by some businesses to help with contact tracing. For example, I know restaurants who are intentionally, even though you have to stay physically separate at the restaurant, they're intentionally logging everyone in, every person who was there, when they came in and when they left, so that if they find out that someone was sick later, they can provide that information to the authorities so everybody there could be tested. So some businesses are trying to step up to try to help with contact tracing. I know Apple and Google have some software they're trying to propose to help with that, but we don't have adequate software testing, and contact tracing, and that's a really big issue. We also really don't have enough tests yet. We're starting to. I think by the middle of the month, they think we're going to be close to where we should have been a month ago, like the middle of May, they hoped for us to be. You need both of those things together, and then you also need people to realize and agree that they still need to socially distance, or physically distance is a better word, and wash their hands and wear their masks when they're in public. So I think the guidelines that they set forth are good. The states aren't all following them, right? A bunch of states open without any of that. In fact, even we were surprised in the US, even President Trump told Georgia, don't open, you're not ready, even though he's been pushing for everyone to open, right? So.
Anyone has a question? Anyone want to step in making a question?
I can ask a question. Hi, Karim. This is Paulo. Thanks for the presentation. Have you considered collecting data and trying to calibrate the model to data? And if not, do you know of other groups that might be working with the CDC that are pursuing this type of approach?
That's a great question. So a lot of people are working on trying to calibrate this to data since there's more data now. I have not tried to calibrate this particular model yet. Bob has spent a lot of time. I mean, it takes a lot of time trying to calibrate his version of the model, his model that uses conveyors and is disaggregated by severity to New York. And it's pretty darn close. So it's pretty interesting. But the goal for us is we want to calibrate that model for every state, because one of the problems with my models, we don't necessarily really have the right information for there are tons of parameters for the contacts. And I think if you assume there's if you assume certain contacts fractions, if you assume that, maybe you can calibrate it. So maybe I should try just with that. Our goal is to calibrate Bob's model, which is a little simpler to understand, to every state in the US and release that. But so far, we just have New York. And that took forever. It takes a lot of time because you also have to partially vet the data and all kinds of problems.
Yeah. No, I recognize. No, I was just wondering, and if you were thinking about calibrating to different states or different counties, whether there was an integrated source for the data. You know, the Johns Hopkins University the database they have at the state level, but they're only, you only have 3 flows, right? So you have confirmed cases, you have deaths, and I think recovered.
Right. Those are the 3.
So not a lot of data.
Yeah, there's not a lot. And Bob used the data that the New York Times has, which came originally from Johns Hopkins, but they massaged the data a little bit. He said that made it easier.
So meaning like 3-4 day moving average, is that what you mean by massaging? Or
I would guess they probably went through the data and tried to find things that didn't make sense and dealt with them.
Okay. Thank you.
Thank you. And you know, the CDC, I know they use our software and they also have other models, and I'm sure they're trying to calibrate to different things as well. And that's how they're coming up with their estimates of when the next one may happen. The problem is, and Bob spent some time last week showing the results of his calibration. The problem is there's so many things we still don't know, and you may end up with dramatically different parameters for things that you think shouldn't change for different places, which then makes you wonder about it.
Yeah, I mean, on that point, I have been calibrating to data from here, from Ticino, and also working with folks from the University of Cambridge with data from the UK. And we're setting up a group. I mean, we have a group, we're collecting data in Brazil. But I mean, the problem, as you pointed out, a lot of the data is, I mean, so the data from the UK, for instance, is horrible. There's a lot of inconsistency. Here in Switzerland is much better, but I have direct access to the, you know, to the cantonal authorities, and it's a smaller system. So, but even then, you have these the contour of the optimal function is very flat. So it's exactly as you're saying, that you have a combination of values for different parameters that lead to the same optimal, but completely different different values for these parameters. So you have to make a whole bunch of assumptions that we don't know, to try to get to values that are reasonable. I mean, it would be interesting to learn from your challenges, you know, and if you're saying that Bob has been doing some of this. I missed the I missed the presentation last week. I'm going to watch the video.
Great. Yeah, I encourage you to talk to Bob about the challenges he's run into. He talked about some of them last time. He's of course talked to me a little bit about some of them, but I think that would probably help you a lot if you guys talked.
Yeah. I'll reach out. Thank you.
You're welcome. Thanks for the question. Thanks for coming.
Any additional question?
I had other questions, but I can wait. So one of the things, I don't see anybody else asking questions, so I might just make another one. So one of the things for testing, you haven't considered false positives or false negatives, nor tested the susceptible population. So I was just wondering, what was the thought process there?
Yeah, so there is, I didn't show the whole model. I just showed a small thing.
Okay.
There is an effectiveness of the tests that takes out false negatives, right? I mean, basically, it says I'm only going to get this many that are actually right. And you'll notice I'm testing exposed and susceptible. I have to be testing that. I don't know who's exposed.
Yeah, that was the.
Yeah, so the testing is the testing has to be in those groups. It can't be in, you know, those groups together.
Okay. So it was just not in the diagram that you showed.
Yeah, well, the diagram shows the movement of people through the system, and the susceptible people, if they don't test positively, aren't going to move out, right? They're just going to stay where they are. They have to be exposed to test positive, so they only move out of there.
No, I had this problem with the data. That was why I was because we have a lot of negatives. So so I have data for tests, and then I have data for negative tests, and so at least with the data, you just have people showing up at the hospital, either worried or with symptoms, or their general practitioner has asked them, or they have requested a test to their general practitioner. So the question is, well, you have an inflow of people that are potentially going to go to the hospital, but so here you don't know which stock they're coming from, right? So they can come from the susceptible, pre-symptomatic, symptomatic, or asymptomatic, right? Now, at least as much as we understand. And of course, there are a lot of false negatives or proper negatives. So these are people that are susceptible, but maybe in the vulnerable cohort. And and then they just show up to tests. They get a negative response, so they go back to the susceptible. But at least in my model, I included an outflow from the susceptible, so that you basically account for that in the testing data, and then I had to put them back in the susceptible stock.
Right.
Once they are rightfully testing negative. Yeah. No. So that was just.
We just aggregate the testing and say, okay, we did these tests. We don't bother to move them in another category. Although it is true, Bob's model does actually separate. No, I think they still have to be exposed for them to move out, tested positive, right? But mine's tested positive is also separated.
Yeah. So those would be testing positive. Yeah. But you know, so from the data, what I have here is, I don't know, 90% or I mean, it varies a lot day by day. But when you look at the cumulative values, you have, I don't know, 85% or so of the tests that are conducted are negative. Now, many of them, people are rightfully categorized as negative, so they are susceptible. They showed up because of a random thing. Man, maybe they just had the flu, or they were just worried. But that, I mean, at least when I was thinking of the original way to capture that, you know, we were basically capturing from all of the other stocks, right? The pre-symptomatic, exposed, asymptomatic, and symptomatic. No, but that's good. Okay, so those were my questions. Thanks, Karim.
No problem. Thank you.
Well, from what I see is just only the five of us. Hamilton, Raquel, do you have any question?
Hi, so Raquel here. I guess Paulo already asked all my questions.
You, Hamilton, you have any other question?
This time I have to entertain my young daughter, so I'm paying attention, but I have no.
Okay, Karim, maybe we can profit a few minutes. I don't know if it is a specific question on the model, if it is addressed. We have been talking a lot about the vaccine. That should be one of the reducing or the most important thing to reduce the pandemic. And normally, a lot of people was arguing. I mean, the perception was the quicker vaccine that has been developed, it took 5 years. People were talking about 18 to 24 months to get the vaccine, but now people is talking about getting a vaccine by September. I don't know how viable this is, but that's something that I have heard from I would say from different sources. But there is also a concern about the effectivity of this of a vaccine developed so quickly. So, what's your perception and how it could be included or make it into this whole model and all this simulation? I mean, the introduction of the vaccine and a vaccine that works or maybe have some side effects.
So the fastest vaccine that has ever been developed took 3 years. There's no way we're going to have a vaccine in September. That's just not possible. In the US, everyone who's an expert, which means not the White House, but the Center for Infectious Diseases, et cetera, says it's going to be 18 months to 2 years, and that's fast-tracked. They don't think they can speed it up there, even though this date of actually January of next year is being thrown around. But I think that came from the White House originally. So the problem is, in the United States, they pushed through vaccines back in the 50s and the early 60s, and they led to horrible consequences. So in the late 50s, sometime mid to late 50s, they had the polio vaccine. They pushed it out the door, and the vaccine actually gave 200,000 kids polio, and a lot of them died because it wasn't properly tested. So that's one outcome. It's too strong and it kills you. It gives you the disease. The other outcome was in the early 60s, they pushed another one out the door really fast, and it actually was not effective at all. And it turned out everyone who thought they were okay, they were no longer careful, and they all got sick for different reason. That's why in the United States, at least, I assume in Europe as well, I can't speak for anywhere else, there are protocols in place that you have to go through to determine what the correct dosage is so that it's both effective and it doesn't have negative consequences. And those require various stages. I guess there are 3 phases in all of different size test groups. And you need to finish one phase before you can go to the next phase. Right now, because the one phase informs the next about changes that they want to make to dosage in particular. And right now, with this January date, they're throwing around this idea of trying to combine phases 2 and 3. And that's basically saying there's only 2 phases instead of 3 phases. It's going to end very badly, I think, if they do that. That's to get it earlier. If they don't do that, they're thinking the earliest they'd be ready is September of next year, not this year. And if the plants that are supposed to manufacture these, they're already starting to build some. They don't know what they're going to need to do to make it, but they're starting to build them so they're ready to create the vaccines. If they're ready to go at that point, we should have vaccines being churned out pretty quickly. And by the end of next year, a lot of people should be vaccinated. But September of this year is not happening. The earliest, the only thing that I've heard anyone say with any confidence that may happen by September of this year is treatments. Treatments also changes the picture, right? So they're hoping to have effective treatments by September of this year, and that does change the picture quite a bit because you can lower the death rate a lot if the treatments are effective.
Yes, but even the treatment, I would say, even in this couple of 3-4 months of the pandemic, protocols, medical protocols, has been changing in the whole world. I mean, at the beginning of the pandemic, people were entering the conditional probabilities to die was higher than it is today. So there has been really a learning on the medical protocols. So even if it is taking more time to get would they say approved treatment, it has improved. It has improved. So now
Definitely.
it's going to be 2 very game changers: the vaccine and the real medicine, or I would say a proved medicine. However, if it is not, if all protocols, as you were saying before, so good regular protocols are not followed, there's a very high risk. So I would say the same as your model is showing the risk related to these vertical isolation policies. There could be also a contribution on showing the risk and how serious it is to try to push so quickly a vaccine that is not ready.
Right. In particular, the death rate could go up or the contact rate could go up, right? For the infectious people.
And even side effect, I mean, is without wanting to enter into the chloroquine, I would say, polemic. Everyone knows, and it's known from before, that the chloroquine has impact on the heart rate. So that's why it doesn't mean that you cannot use chloroquine. It means that you have to make a good diagnosis of your patient and see if you can use the doses and so on. So it's the same. I mean, it's the same with the treatment. With the treatment, you have to have a good knowledge of your patients and follow the right protocols.
Yes, for sure. Right. Too much of a dose will kill someone, and not enough won't fix it.
Yes, you can end up having side effects that are not even into the same, I would say, field of this disease. You can have other kind of side effects. That's the point mentioned. That was my example. My example about the chloroquine. You can start having heart attacks or whatever. I don't know. Okay, so any additional questions or? Okay. So Karim, well, you are here.
I'll just wave goodbye before we go because I had to turn it off because my internet's not strong enough.
Okay, okay. Well, thank you very much, Karim. It was a very constructive discussion. We are all in here, the one who participated or interested on the virus, interested on the modeling. It was a very interesting, I would say, discussion presentation. Thank you very much, Karim, and thank you also for providing all the platform you have been doing all these webinars.
Thank you, everybody, for coming. I appreciate it.
Okay, so good evening. Thank you very much to
Boa noite.
you all. Thank you.